Great, thank you very much. It's very nice to see you all. And just to try and stop you all going to sleep after lunch, I'm going to expose myself to you here and try and give you a slightly less cerebral but nonetheless provocative talk, really as a simple clinician who's interested in trials and improving healthcare. So the lecture's called The Advent of a New Era for Clinical Trials, and I suppose as you reach your decade of investment by HRB, I'm here to give you a few ideas about how HRB can continue to fund you for another 10 years, as Peter was referring to earlier, because you will undoubtedly need to refresh your mission and add a few other important aspects to what you're already doing. So I'm paid mostly by a university. I'm paid by a state-funded healthcare system in which I deeply believe and I'm very proud of in the UK, even though it is struggling. And I'm also paid by the UK CRC clinical network of clinical trials units. So I'm not going to say anything bad about clinical trials units, obviously. All the grants and consultancies of mine are paid to my employer, but I think more relevant about me are my non-financial competing interests, where I think, like you, I'm deeply concerned about the amount of waste that exists in research and how we actually know already how to make it far better and far more efficient. And we're just ignoring what we already know. And I come to you as somebody who feels guilty about having got on a flight from Edinburgh to Galway to come and see you, and I'm now really choiceful about when I do get on a plane. I've got a limit on the number of times I travel each year, and I only go long haul maximum of once a year, because I think we have to make personal responses to climate change, and that's going to be part of this lecture now. So thank you for inviting me. I've enjoyed breathing the air in the Galway Bay, running 10 kilometres along your coastline this morning, and I'm ready to eat your fish this evening. So the lecture title is deliberately heralding another 10 years for you, but also recognizing we're just before Christmas, and this is a non-denominational approach to the season of Advent, which I think has got some core values that I think we can perhaps all turn to, because like Janet, I'm rather troubled by many of the things that are happening in the world, but I think we have it within ourselves to respond to them. So I'm hoping I can offer you a few ideas about hope, peace, joy, and even love at the end of this lecture. So first of all, hope. Well, I've told you I'm already really concerned about climate change, and I think other than the flat earthers amongst you in the audience, we must all surely be concerned about climate change. The problem is a feeling that's provoked by seeing this polar bear floating on a tiny bit of ice, is we all feel overwhelmed by it, difficult to know what to do, and it's quite traumatic, especially for our children coming into a world that is like this. So it's far better to look at the much more hopeful side of environmental activism and recognize that there is a sunny world to be aspiring to, and that we can make what we do more environmentally sustainable. And that, as many of you know as trial methodologists, is largely about behavior change. So would this puffin here be referring to environmentally sustainable clinical trials? Well, I think the only thing I can really take credit for contributing to the TMRP's greener trials movement is that I suggested to them we should call it greener trials. We've got some great campaigns, haven't we, that have changed things with trials. All trials registered, all results reported. We've got more trials, doing more trials better, and so on. And I think we need greener trials as well as a movement. And of course, as we have known about global warming and climate change since the 19th century, but it's really only been properly and forensically documented since the 1950s, going back to the decade that Janet was referring to, we have also known about the need to do more environmentally sustainable clinical trials for quite some time. And this was going back to what Ian Roberts, I think, christened as the Sustainable Trials Study Group back in 2007 in the BMJ with Mike Clark and various other people on the list there, Janet Derbyshire and so on, people saying that this is really important and we need to learn how to do trials more sustainably. But this group has withered away, sadly. It was a grassroots movement, if you'll forgive the pun, that kind of died out, because I think Ian Roberts just got overwhelmed with doing some challenging mega trials. This paper on a really important topic that we could have done more about for the last 17 years has been cited a total of 51 times, which tells you how interested everybody is in this area. And surely we've got to be more interested in it than that. And in that paper, Ian and colleagues quantified the carbon footprint, and I think this is the first carbon footprinting of a clinical trial that was done, of the CRASH trial, a massive trial of corticosteroids for people with significant head injury worldwide. And one of the interesting proportions here is that it's actually the buildings we work in and our own choices about how we travel to work and so on that account for a large proportion, more than a third of the carbon emissions of clinical trials. And even then, there were some very simple suggestions about how we can make trials more sustainable and how we can reduce emissions. And you can see them listed there. So there's obviously emissions of our buildings and our clinical trials units, the way we travel to work, both ourselves as people who do trials and also the patients and how we choose to do them. And obviously, Connor's going to be talking to you about AI and remote trials and data-driven trials, and that's one solution to this. But the compute power of AI, of course, is absolutely huge, and I don't think these things are necessarily a done deal, so we need to really think about this hard. The other thing that Ian Roberts and his group showed quite significantly a few years afterwards, and again, this is a paper that's now been cited only 58 times, isn't this dreadful? He showed between CRASH 1 and the CRASH 2 trial, which was an antifibrinolytic for significant hemorrhage, that it was possible to reduce carbon emissions by changing how they conducted the trial. Not a randomized comparison, I'm afraid, Janet. It's a non-randomized comparison of apples and pears, but at least he showed it could be done. And I think this is motivational. We can reduce the carbon footprint of what we do. And in fact, buried deep amongst their many other guidelines on a website in the UK is the National Institute of Health and Care Research's carbon reduction guidelines, where there are 19 recommendations about how we can do greener trials. Yet we've made these recommendations and parked them and not really positively incentivized their use in the way trials are either adjudicated by funding committees or regulated by regulators, which have been effective approaches with things like, for example, trial registration. Very important scientific principle, but we're talking about globally important issues now. So I won't repeat what's said on the slide there, but you can see inherent in this is it's okay, everybody, you're already doing the right thing, because this is an audience of trial methodologists, and doing trials efficiently and when they need to be done, and not doing trials that don't need to be done, is in your lifeblood. And so the first rule of reducing our carbon footprint is don't do trials in the first place if they never needed to be done. So you're already doing the right thing. We just need to do the trials that need to be done better and greener. So that then in 2021, a group of us, along with Richard Smith, previous editor of the BMJ, who's a great guy to have on board whenever you want to start a movement and be an activist, we basically said, well, here's a strategy to reduce the carbon footprint of clinical trials, building on what the NIHR had already told us about how to do that, and recognizing the other stakeholders in this, including patients and their carers and the public, to demand greener clinical trials. Incentivize doing them, look at other approaches like value for carbon, not a simple concept, but something methodologists like you could probably come up with a good answer to. And first of all, develop a tool to measure trials' carbon footprint better, because we didn't even have that. We've had what Ian Roberts did in CRASH years ago, but the world is now much more eloquent in doing carbon footprinting in a variety of contexts. So let's get on with it. So it's telling that within a year of this editorial, multiple industry partners have already done this, more or less. The pace at which we work in the academic world is so slow that they've already gone ahead of us, and we're at risk of about 5 or 6 different carbon footprinting tools for trials happening. We're too slow, and this is too urgent. So it's a big partnership of different people. Started this lower carbon in clinical trials movement. I've called it greener trials, and I've made them a logo, which I think, as 2 olive branches, is symbolic about the kind of hope we want to convey in this area, and also maybe suggests randomization. So the intention of this funding, and this was support for clinical trials unit funding, which led to the development of a carbon footprinting tool. It was just for a year, and we've come perilously close to losing a wonderful woman, Jess Griffiths, who's led on this, who was only given salary for a year, and we're desperate not to lose her. And that's how difficult it is to keep a grassroots movement going. I don't expect you to be able to read this, but this is simply to say the process map on the left is complex, as you would imagine for a trial, but that's actually pretty simple when you've got all the moving parts of a trial involved. So there is a process map, and there is a first draft of a tool which has now been applied to 10 different trials, and you can just simply see from those pie charts which show you the relative contributions of the different aspects of clinical trial conduct to carbon footprint, that they're wildly variable, and that'll be influenced by things like their their design, their methods of follow-up, for example. But those orange segments are the trials unit emissions and staff travel, and they remain a large part of the emissions in many trials. So much like Max's MAMS clinic that he runs for people interested in multi-arm, multi-stage trials, there's also a drop-in clinic for people who are interested in carbon footprinting clinical trials run by this group. You can see the URL at the bottom there. And the intention now is to grow people who do clinical trials, who think this is important and use the tool, and then obviously be working towards making it as user-friendly as possible, embedding it in our everyday clinical trials practice, and in particular looking at interventions to reduce the carbon emissions of trials, maybe even in an experimental fashion, to learn more, because that's our natural answer to most things, isn't it, to randomize. And commercial trials are already all over this because they are commercially incentivized to reduce their footprint and have got all sorts of commitments in that area. So that's the longest section of my talk. Don't worry, they're not all going to be as long as that, but it's the amount of time I spend is proportionate to the importance of the issue. So what about peace? So I think, to conclude that, there is hope. There has to be. We can all do something in our own small way, in our everyday jobs, about climate change. I'm sure you could all think of a way of making any of the trials you're involved in more environmentally sustainable or greener. So what about peace? Well, this is more about making peace over the issue of research waste, which a lot of people find rather indigestible and don't like it. So this was back in 2009. Ian Chalmers and Paul Glasziou wrote that very provocative article in The Lancet, saying that in 4 stages of research, which didn't include the middle one at the time, there was very good evidence from research on research, meta-research, that 50% of studies fail at each level, whether it comes to involving users of research in their design, or whether it comes to publishing usable research support. So 50% of 50%, 50%, 50%, so more than 85% of the investment in research is actually wasted because of poor methodology. And all of those sources of waste may add up collectively to research waste, individually or one on top of the other. But in a positive way, again, we're encouraged to put together recommendations about how to reduce waste and then how to monitor it. And this was a grassroots organisation that again floundered because it wasn't securely funded. And I didn't know HRB were going to be here, but I have given you already examples of 2 really important movements that have just withered because there's no infrastructure funding. So it's great that you have that. You do great work, and it just shows you how precarious it is to do the right thing rather than do something that makes money, which people find much easier to back. So yes, I got into this because I had written lots of protest research about how burdensome regulation is, and shortly after the Lancet series was published, I got a charming invitation to submit an article to the International Journal of Waste Resources, and I thought finally the movement had got traction. We had a house journal, and waste in research was a massive issue, but of course they were much more concerned about a different source of waste, and this was obviously a predatory journal request, but I was grateful for their recognition anyway. So in order to make peace with everybody about this issue, I think we need to recognize some of our human failings, like ignoring the climate crisis and carrying on with environmentally unsustainable behaviors. One is that people are obsessed by quantity and not quality. You're not, I know, but human nature tends to be like that. We need to address priorities where they exist, so the partnership work we do on setting priorities is terribly important. And so on. Methodological rigor. I'm not going to touch on any of these topics because you've got far more inspiring methodologists on the program than me, but I do think that's really important, and the patient and public involvement tremendously important. But I do think we need to do more research in research to improve efficiency, so SWOTs, and more research on research to monitor progress about how we're adhering to things, and we've seen that with trial registration. That meta-research has been helpful in driving up standards, and I think we can do it with these other initiatives as well. And finally, I think, again, in a hopeful way, I think we are starting to make peace with this issue of waste, in that, I think you've got an HRB-TMRN event tomorrow, haven't you, about the recent WHO guidance, but I've listed some of the things there that the new WHO guidance for best practices for clinical trials is expounding, and I think much of it looks really good to me, recognizing sustainability both in terms of the people involved in research as well as the other forms of sustainability, keeping up the pressure on regulators to become ever more streamlined and efficient, incentivizing new researchers. We've got a crisis in clinical academia for sure, with the next generation not coming through because it's such a demanding career, but we need to recognize that and positively incentivize it. And keeping on going with regulation and enshrining PPI and E even more in what we do. So I see that as quite hopeful and pushing the right buttons for where waste has arisen. So what about joy? Well, I think the joy in what we do comes from us being together as people and working on trials. It is team science. We have the privilege of, it's not like me going on to a ward, working mostly with doctors and nurses and maybe a few other allied healthcare professionals. We've got so many disciplines that you can't read here inside a clinical trials unit, and I haven't even put the medics or allied healthcare professionals on that diagram. But it does mean that we need to learn how to work together and how to bridge the clinician versus CTU interaction, the black box of a clinical trials unit to clinicians, and how we can work really successfully together. And also recognize that medicine and other professions allied to it haven't always taken the most constructive approach to learning difficult tasks, because certainly how I was taught was this old medical mantra, see one, do one, teach one, and Connor looks like he recognizes that as a fellow medic, and so that's just how we were taught. But you cannot see one, do one, teach one with trials. There's no doubt about that. So that's why on my own as a clinical director for our trials unit, I need to surround myself by my own people and also use them to spread the word about how to work well with the community. So we've got a clinical advisory group made of a variety of different people from different disease areas, different types of interventions, as gender balanced as we could, including myself that's Mabel, my oldest dog, in place of me. And we work collectively to engage with the community of trialists, including the precious people, the first time, the new chief investigators, to get them on the right track about how to work with the trials unit and reinforce the importance of things like PPI&E, trial methodology, doing SWOTs in trials, all the obvious stuff that they weren't taught at medical school. And Dave Sackett's already been mentioned, and here he is again in a second lecture. And the only place I've ever found a manual for people like me on how to go about doing trials as somebody experienced in my own specialty but completely clueless about clinical trials are these things that Dave Sackett wrote, the Clinician Trialist Rounds, and there are about 27 of them, and they're like a Sunday supplement article, at the back of a magazine, Saturday supplement, sorry, just a column, on a really important issue with brilliantly distilled words of advice. And I advise any of you who are unfamiliar with trials, or who are healthcare professionals here doing trials, to read these. They're full of sage advice. Unfortunately, I'm not Dave Sackett, so my response to this with my own trials unit is to write a coaching program for first-time chief investigators, which you see in a very unattractive document there. But the essence of it is that we all need coaching and mentoring in our professional roles. It really helps. You don't need to have it in abundance, but you need to have it from the right people at the right time. And mentoring is obviously a developmental thing for you as an individual, but coaching is something much more targeted that I think first-time chief investigators of clinical trials need from somebody more experienced to see them through the process. Otherwise, they're just learning on the job. They haven't even seen one. They're just doing one. And so that's why on a UK level, amongst the trials units, we've also got a Chief Investigators Network group. And we're doing things like writing template role descriptions for clinical directors. We're creating a blueprint for a coaching program that trials units can use if they want to with their chief investigators around the UK. And so the last message, and again, I knew Janet was going to talk about Trump. Well, you may not even have mentioned him by name, actually, deliberately. So just again to reflect on ending this with some love, it really pains me to be showing you a document that was produced by Boris Johnson's Conservative government. But this was something called Saving and Improving Lives, the Future of Clinical Research Delivery, because the thing that I love about it, which is also a problem in clinical trials, is that they're not yet fully embedded in everyday clinical practice, which is also something I think needs to happen more. And these are all sorts of recommendations about not only speed and efficiency, top left, using innovative research designs, which Max will talk about, I'm sure, aligning research with what's needed in the population, that's prioritization, something you've already got covered, right at the heart of this, patient, public and service user involvement, which was good to see from the UK government. Making research much more visible, normalizing it in everyday practice. It's still something that many of the doctors and others who work around me regard as the work of boffins and somebody else's job. But this needs, the altruism thing that Janet was talking about is so prevalent amongst patients when you sit down and talk to them about what they care about, at least in Scotland it is, that I think connecting with that makes it really important, and seeing it done. As what happens in cancer, every patient asks, and which trial am I going into? But in cardiovascular research, neurological research, they don't. It's completely alien. So we need to make all specialties like cancer. Digital platforms, Connor will talk about that, and making it more diverse and relevant to the whole population, something that Sean's very strong on with many of you. So for a Tory government, this was absolutely amazing document, hitting all the right, undoubtedly it was written by advisors, not by Boris Johnson, but I do love that vision, which shows to me that despite my concerns about climate change, about waste in research, and about the approach we've taken to team science in the past, I think embedding clinical research in everyday practice offers, again, hope for an advent for a new era of clinical trials. So I hope I've given you a few more hopeful messages, even though they're all based on problematic scenarios. And I just want to end with my puffin. I think it's the same word in Gaelic for puffin, but not quite pronounced the same way. But they're called tammy norries in Scotland, which is quite a cute name for a puffin. So what would this puffin want to say to you at the end of my talk? And I think the first thing the puffin would want to say is carry on doing what you're doing, only do really good trials and don't do them when they're not needed. I think this puffin is down with, prevention of trials that don't need to be done. Second thing I think this puffin would say is, do greener clinical trials, please, for me and the rest of my family in its borough. And the third thing, which I haven't talked about, but is what I'm thinking I really need to switch to, is do trials of interventions to make healthcare greener. I think that's the other way. We not only do clinical trials that are greener, we obviously need to treat disease and we need to reduce disease burden, but I think we also need to do trials of interventions to do this. Our NIHR, I don't know about HRB, has got funding allocated for this, but they're not using it all. People aren't coming forwards to respond to one of the biggest threats facing us right now. But maybe somebody will listen to my puffin. Thank you.